presentar a Tiia Ngandu. Ella és una investigadora del Departament de la Prevenció de Trastorns Crònics de l'Institut Nacional de Salut i Benestar de Helsinki, a Finlàndia, i de l'Alzheimer's Disease Research Center de l'Institut Karolinska d'Estocolm. Ella ens parlarà sobre l'actual comprensió de la prevenció de la demència i específicament centrant-se en el paper de l'estimulació cognitiva, la dieta i l'activitat física. Doncs, whenever you want, Tiia, it's your time.
So good morning, everyone. Thank you very much for the opportunity to come here and speak to you today, and many thanks for the invitation to come to beautiful Barcelona. My talk today is about prevention of dementia. I will start by going through the occurrence and the projections in the future occurrence of dementia and Alzheimer's disease. I think all of you know that Alzheimer's disease is the most common form of dementia. It accounts for about 70% of all dementia. Then I will go through the current evidence about risk factors. What do we know about risk factors of dementia? And then the last bit of the presentation, I will go through the interventions that have been conducted so far or are ongoing. I will spend a few last minutes also giving some information about our own intervention trial called FINGER. Why is prevention of dementia and Alzheimer's disease so important? It has been projected that just because of the aging of the populations, the number of persons with Alzheimer's disease is going to more than triple in the next 40 years. So the upper black line here shows how the number of persons with Alzheimer's disease is going to increase given the age structure of the population. Now, if we would know how to not prevent completely, but just to postpone the onset of the disease by just 1 year, it would go down. The expected prevalence would go down this much. And if we could postpone by 2 years, there would be quite a big decrease in the expected prevalence of the disease. And of course, the impact would be much greater if we would know somehow how to postpone the disease onset even further away. There has been quite intense development of drugs for Alzheimer's disease, but the results have been quite disappointing. In the center of this graph, you see the 4 drugs that are currently used, and they are symptomatic. They do not cure Alzheimer's disease. There have been many compounds that have been tested, but so far we do not know how to cure the disease, so that's why even more emphasis should be put on the prevention. There have been also non-pharmacological therapies that have been investigated. Their effect is about the same size as those of the currently used symptomatic drugs. To be able to prevent Alzheimer's disease, we need to understand a little bit of the disease process. There have been neuropathological studies and lately also imaging studies showing that the typical changes, amyloid plaques, start to accumulate decades before the first symptoms appear. So it's very important that we think about the whole lifespan when we think about risk factors and when we think about prevention of Alzheimer's disease. Most likely it is a combination of both genetic So most likely it is a combination of both genetic and environmental factors that will determine who will get the disease and when. In the last years, there has been more and more research focusing also on the early stages of life, looking at risk factors. Also here in middle age or even earlier, as those might be the stages where we might actually find something that we could intervene on to prevent the disease. There have been The research on Alzheimer's disease risk factors is quite young still. There have been prospective cohort studies ongoing for perhaps 20 years. So it's much younger science than that of risk factors of cardiovascular diseases, for example. If you look at the list of identified risk factors, you see that many of those are the same risk factors as can be found behind cardiovascular diseases. So you see, you see there's hypercholesterolemia, obesity, hypertension, smoking. What is nice is that the list of protective factors is getting longer and longer all the time. So there are different lifestyle factors: physical activity, cognitive activity, healthy diet. As said, so far the evidence comes mostly from observational studies. So we have compared people who have different lifestyles and looked at who will get the disease later on. In the next few slides, I will present some data from these different risk factors. This figure comes from the CADE study from Eastern Finland, where we have information from the midlife risk factors. So here we saw that persons living alone, not being married, not living with a partner at midlife, had actually twice as high risk of developing dementia or Alzheimer's disease 20 years later. Of course, we do not know why this is. They might have otherwise healthier lifestyles, or it might be the cognitive stimulation that has to do with living with somebody. These data are from the Kungsholmen project. There the participants were 75 years old to begin with. So there they looked at different activities in quite aged population. And they saw that different kinds of activities, both mental, physical, and social, are all important in protecting from dementia. Then moving on to physical activity. This is again from the CADE study. So we saw that the people who had regular physical activity at their midlife in their 50s had quite a lot smaller risk of dementia and Alzheimer's disease 20 years later. They also had greater brain volumes. We had a subsample with MRI imaging, so we saw that the brain volumes were greater among those who were physically active. One perhaps mediating factor might be the brain-derived neurotrophic factor that has been shown to increase with physical activity. Then about healthy diet. There have been quite many studies with different definitions of what has been healthy diet. First, there have been studies with single food items like fish or fruits. And then there have been studies looking at intake of different vitamins. And more later on, there has been more emphasis on the dietary patterns, so not just single food items, but on dietary patterns. All of these have been seen as decreasing the risk of developing later dementia, but the findings are not so clear, so there are also studies showing no association. So it's a bit open discussion still. Then, to make the picture a little bit more complex, we have also looked at interactions between genes and lifestyles. In the CADE study, we have assessed the ApoE gene. That's the common risk factor for developing Alzheimer's disease, and it's quite prevalent. In Finland, we have like 30% of people who have the ApoE4, the risk allele. So in the CADE study, we actually saw that the effect of different lifestyles was much stronger among those people who already had the genetic susceptibility. Here we have the physical activity. This is polyunsaturated fat acid intake. This is saturated fatty acid intake, alcohol drinking, and smoking. So we see that all of these lifestyles seems to be a little bit stronger. The association between lifestyles is stronger among those who have the genetic susceptibility. Turning around, it's actually quite good news for those who actually have the gene, because they, with their lifestyle choices, they might be able to reduce their future risk of the disease. Then, as I said earlier, a little bit about the life course perspective. For some of the risk factors, it has been shown that risk factor can be important at one point of life, but not so much later on. One example is, for example, high cholesterol levels. So we have seen that high cholesterol levels at midlife increase the risk of developing dementia and Alzheimer's disease later on. But then if you look at older populations, there you see that the persons with Alzheimer's disease actually have lower cholesterol levels. So in older age groups, it might be actually a marker of the disease process. So the cholesterol levels are declining with the disease. So it's just saying that life course perspective is needed when we assess the risk factors for Alzheimer's disease. Then, of course, a person is more than just one risk factor. We all have our own set of different risk and protective factors. Using the data from the CATE study, we tried to develop a risk score instrument that would take into account several different risk factors. These are not all that there are, but some. And we actually saw that persons who had more risk factors or higher risk score based on this instrument also had a higher risk of developing dementia 20 years later. So this was prediction over a 20-year time period. Of course, this is no screening instrument and it should not be used as such, but it's more of pointing out who should pay more attention to their lifestyles. And perhaps an extra motivation for some people to focus on healthy lifestyle. Then here is quite interesting study a couple of years back where they projected the effect of decreasing different risk factors. So you probably can't see the risk factors, but they are here. They are diabetes, midlife hypertension, midlife obesity, depression, physical inactivity, smoking, cognitive inactivity, and the last bar is the 7 risk factors combined. So the lighter red bars show what would happen to the future prevalence of Alzheimer's disease if the risk factor level was reduced by 10%, and the darker red bar shows if the risk factor levels were reduced by 25%. These estimations are based on both the risks related to the individual risk factors, but also to the prevalence of those risk factors in the population. So actually there would be really huge impact. There would be like 3 million cases of Alzheimer's disease prevented worldwide if there would be such a changes in risk factors. This is of course only projections from observational studies. This is no data from the intervention trials. Last year, the CFAS group from England published results on what has really happened to the prevalence of Alzheimer's disease, or actually dementia, in the past 20 years. They saw, quite interestingly, that actually the age-specific prevalence has decreased a little bit during the 20 years. So the number of persons with dementia has not decreased, it has increased because there are more and more old people. But the age-specific prevalence has decreased a little bit. This might be actually indirect evidence that some changes in the background, in lifestyle, education levels, or so on, might be reason for this. We do not know for sure what is causing the change, but most likely it's something in our lifestyles. There are big changes in the lifestyles in different populations. These are figures from Finland. They go from the 70s until 2 years back, showing that there has been really big decreases, positive development in the level of cholesterol, in the prevalence of smoking. But on the other hand, there has been quite worrying increase in BMI, increase in alcohol consumption, increase in prevalence of diabetes, and so on. So at this point, it's really, really difficult to estimate how all these different trends in population will result in the future occurrence of dementia and Alzheimer's disease. Everything that I have shown so far comes from observational studies, and that is always the first step to go when we are thinking of prevention. We need to first identify the possible targets, but then the real evidence showing that can you prevent and what should you do to prevent comes from randomized controlled trials. And at the moment there are not so many randomized controlled trials. So the evidence from them is not so convincing yet, but I will present the current status in the next few slides. The first trials were on different drugs or supplements. They are a little bit easier to conduct this kind of trials than lifestyle trials. There were, for example, trials giving these dementia drugs, the acetylcholinesterase inhibitors, to people with mild cognitive impairment to see if that could prevent developing AD, but it didn't work. There have been some trials using antihypertensive drugs showing perhaps positive effect in some subgroups of persons. Statin trials showed no effect. There have been trials using estrogen or even non-steroidal anti-inflammatory drugs, and there actually they even increased the risk in these trials. These trials were conducted in quite old populations, so it might be that the time window for using exactly these compounds was not really optimal. From the different vitamin supplement trials, there's some evidence that at least vitamin B12 supplementation might be beneficial for those who have deficiencies. But here as well, we're still waiting to see if that would actually prevent dementia. Then there are some new trials with a little bit new strategies ongoing. There are at least 4 trials that have compounds that are targeting beta amyloid as their active agents. Here, the selection of risk groups is quite different from previous strategies. So, for example, in the ADCS-A4 trial, the participants are people who already have evidence of brain amyloid in the PET scans. And then the API trial and the DIAN trial, there they include people who have this early onset hereditary mutations of Alzheimer's disease. They are very interesting studies, but in a way the early onset forms are quite rare and they are quite different from the late onset forms of Alzheimer's disease. But it will be interesting to see what comes out of them. And then the last trial is selecting patients based on their genetic risk factors. All of these studies have just started, so we need to wait quite a while to see their results. Then a couple of slides about lifestyle trials. There have not been so many, as they are a little bit more complicated to conduct. One of the bigger trials is the ACTIVE trial from the US. There they had 4 different groups of persons. It was about cognitive training. One group received training in reasoning, one group received training in memory, one group received training in speed, and then there was a control group. In this study, at first they showed that the cognition improved in those areas that were trained. That was quite expected. And then now they have published the 10-year result showing that the training was also showing improvements in the instrumental activities of daily living. So some signals here that cognitive stimulation might be a good way in this prevention road. They do not have published the impact on incidence of Alzheimer's disease so far. Then there have been a couple of quite small-scale trials in physical activity. Here's one trial from Australia, where the participants were selected. They had subjective memory complaints, and they did 1 year of aerobic exercise training, and that showed improvement, or that showed results in the favor of the intervention group in ADAS-Cog scale. And then evidence from another trial, also a quite small group of people. A year-long exercise trial showed beneficial effects in the exercise group when we looked at the hippocampal volume. The results from the MAX trial were published last year. This was a group of older adults that were divided into groups receiving either mental activity or physical activity or both. And the control groups were sort of active control groups. In this trial, they actually showed that all groups showed improvements in cognition, and there were no differences between the groups. So it might be that it's just training effects. It might be that there's actually an improvement, but it doesn't matter how intensive your intervention is, you can get the improvement even with less intensive interventions. There have been not so many trials on nutrition. One is from Spain, the Predimed Navarra trial. Here they had 3 groups. There was a control group was receiving low-fat diet. Then there were 2 intervention groups, one with Mediterranean diet and virgin olive oil supplement, and one with Mediterranean diet and nuts. And at least in the end, they saw a beneficial effect in the intervention groups in the MMSE and in the clock drawing test. And then they had some more information, cognitive data, in a smaller subgroup of persons. And then the effect was not so clear. The limitation of this study is that the cognitive information is only from the end of the study. So we do not really know if the groups were similar in their cognitive status at the beginning of the study. But it's a positive indication that dietary interventions might be useful also for cognition. So when it comes to preventive interventions, we still do not really know when should we intervene, at what time point in life, because the effect of intervention might be most important if we start early, but then it would take decades and it would take lots of resources to have your results. On the other hand, if we focus in the later ages, you will have soon many people with dementia, but you might be acting too late. Maybe there's nothing to do when the disease process has advanced to a certain stage. So now we are thinking that perhaps somewhere between might be the most realistic time window, but we still don't know. Another important thing in the future trials is that we have seen that there are so many risk factors that have been identified. So if we do an intervention on just one factor, maybe the effect is not as great as if we would try to intervene on several, if not all, of these factors. So what would be the recipe for optimal trials? Multi-domain intervention. Then timing. Starting earlier may lead to better effects. Then the choice of target group. If you choose very young group, you will need lots of resources, but then the older group, you might be too late. Then the choice of outcome. There is at the moment no consensus on what would be the best outcome measure. Now we're thinking that some sensitive measures of cognitive decline might be better than just incidence of disease, but currently there is no golden standard in the preventive trials. Then there's also these ethical issues. As we see that many of the risk factors for cognitive impairment are also important in terms of vascular health, so we cannot really conduct placebo-blinded trials. We need to give information that are important for the vascular health of the people. Keeping all this in mind, I would like to present our ongoing study, the FINGER study, where we had our aim was to reduce cognitive impairment. We had a 2-year trial using a multi-domain intervention. Our target population was from 60 to 77 years. They had higher risk. We used a dementia risk score to choose the people, and then we used the steroid battery. So we actually included people who were at the mean level in terms of steroid tests for their age group. So we excluded those who had really good performance. Our primary outcome is change in cognition during 2 years. It was measured with a neuropsychological test battery that is quite extensive. It takes about an hour. It's a set of standard tests. And then at 7 years, we have calculated that then we would also see differences in incidence of dementia, but then also we can see different other outcomes, quality of life, vascular factors, and we have imaging data for a subgroup of persons. We actually just completed the 2-year intervention, and the results should be soonish, and now we are going on with the follow-up until 7 years. This is the description of our intervention. So we have 2 groups. One group receives all this multi-domain intensive intervention, and then there's this regular health advice group. They also receive some advice about their risk factors. So we have nutritional guidance, we have physical activity, cognitive training, and management of vascular risk factors. The nutritional guidance is done in both individual sessions and in group sessions, and it is based on the Finnish nutritional recommendations. But it's also individually tailored so that the needs of our older participants are also taken into account. The exercise intervention, it's progressive, so better you get, the harder it gets. And the main emphasis is on resistance training. Our participants go to gym once or twice a week. They also have balance training and some aerobic exercise. Then we have the cognitive training part that was developed together with the researchers in the Umeå University in Sweden. And it's a computer-based training, and we have tasks that are related to most to working memory, executive function, some episodic memory tasks as well. It's an extension of the training that the group had previously used in a smaller scale, shorter trial. And previously they had shown that the training resulted in improvements in memory and also brain blood flow in PET imaging. But as said, it was enlarged to fit our trial. I will give you one example of the tasks there. This is one about spatial updating. So you should try to remember where the last 4 red balls are. I think you are too professional it shouldn't be too difficult, but we'll see. it too easy for you? It's not so easy for participants, at least. And the thing with this computer-based training is that it gets more difficult as the participants are better. So they actually never feel that they are doing very well because it's adapted to their level. Then the fourth arm of intervention is the monitoring and management of vascular risk factors. There the participants have regular meetings with the study nurse and physician. And this is just based on current care guidelines that we have in Finland. As said, we have now completed the 2-year intervention, and we are very happy at least about the participation. We had only 11% dropout rate, which is really, really good. The participation in different intervention domains, these numbers are quite preliminary. We are still digging into the data. But it seems that at least in the dietary intervention, the participation was very good. It was also quite good for the exercise and cognitive training. We couldn't expect 100% in each domain because it was quite intensive intervention. But this, like different intensities of training, will also allow us to a little bit look at the dose-response effects, hopefully. Our participants have been very happy about the intervention. The intervention group is reporting a little bit more often that they are very positive about participation, but in general they are all quite happy. And some quotes from both intervention and control groups, and they are satisfied. But let's hope that this will also turn into benefits in cognition. In addition to finger, there are other trials as well. Here I will mention there's a PREDIVA study in the Netherlands. They are focusing on vascular optimization of vascular care of the participants. And then there's the MAPT trial in France. They have a multi-domain intervention with physical activity, diet, cognitive training, and then they have omega-3 supplementation. All these studies are ongoing, but we are now actually doing some data sharing and pooling analysis and trying to learn from each other to develop even better interventions. And we are just starting a new project called HATISH, which is a multinational preventive project. And it will start quite soon. So, to conclude, can we prevent, can we delay dementia? Now we have quite a bit of evidence from observational studies that it is important to pay attention to vascular factors and lifestyle. But still we are needing more evidence from intervention trials, so we do not have the definite answers at the moment. But I think it's still quite safe to say that take care of your heart, be active. That's the safest bet to prevent cognitive impairment later on. And here's just a reference to one quite recent review about prevention of dementia that you might find interesting. And very last, I would like to acknowledge we have a long list of funders and then a really large group of experts in Finland and in Sweden who are working very hard, and I'm very happy to work with them. And thank you very much.